Hello, everyone. Thank you all for joining today. My name is Noemi Razzo, and I'm the Clinical Applications Specialist at Millar. I've supported Millar's life science and clinical pressure and pressure volume catheter solutions since 2013. In my most recent role as a Clinical Applications Specialist, I'm involved in the training and case support of the INCA pressure volume loop system. I'm excited to introduce today's webinar, which will entail a discussion on volume calibration in conductant T, the INCA PV loop analysis software. A bit of housekeeping before we begin. All audio from the attendees will be muted during the presentation. There will be a question and answer session at the end of the webinar where I will welcome Jan Schroeder, medical advisor at CLACOM, to participate in the discussion. Feel free to send us your questions as the webinar progresses. You can do that by typing your questions in the questions panel on the GoToWebinar toolbar. You may need to expand the question panel by selecting the plus sign. When prompted to participate in polls, submit your answer in the polls menu. In this webinar, we will begin with an introduction on conductance theory and discuss how Ohm's law is used to derive a relationship between conductance and volume. The second half of the webinar is intended to give INCA PV loop users insight on volume calibration methods in conductant T, the INCA's data analysis software. We will review recommendations for performing reference volume calibration and EF-cal and SV-cal calibration in conductant T. So before we get on to the webinar, I did have a few poll questions, so I will go ahead and launch those poll questions, and you'll be able to go in there and select your answer. So the poll is now open, and our question is, what is your experience with PV loops? All right, so I'm going to close the poll here and share our results. Let's see. Okay, so it seems like the majority of the attendees are actively planning to conduct PV studies. There's a general understanding of the PV loops, and a few here that have performed some PV studies in the past. The second poll question that I have is, are you an INCA PV loop system user? So do you currently have the INCA system and are using it? All right, so let me close this poll here. Share. Okay, so the majority of the attendees of today's webinar do not have the INCA system, but the webinar today is going to focus on the volume calibration methods used in conductant T, but I think it will be a good introduction even if you don't currently possess the system and are using it. Okay. So just 1 second here, trying to get the presentation up again. All right, here we go. Sorry about that. All right, so before we dive into volume calibration and conductance T, I wanted to introduce conductance theory and elaborate on how an electrode catheter is used to measure volume. Conductance is simply the ease at which an electric current passes through an element. We can also think of it as the inverse of resistance, the opposition to the passage of electric current through an element. To measure conductance in the ventricle, the pressure volume catheter utilizes 12 electrodes positioned on the long axis of the ventricle. A high frequency, low amplitude constant current is passed through electrode pairs 1 and 12 and 2 and 11 to create a local electric field between the pairs. The innermost electrodes measure the voltage potential between electrode pairs. The electric field passes through the blood in the ventricle and into the muscle wall. The sensing electrodes will not only capture the voltage potential of the blood, but will also capture that in the muscle wall. We call this the parallel conductance. We will discuss how to correct parallel conductance through the use of hypertonic saline later in the presentation. We know from Ohm's law that voltage equals current times resistance. The PV catheter passes a constant current through the outermost electrodes. Therefore, we can conclude that the voltage potential is proportional to resistance. We also know from electrical principles that conductance is inversely proportional to resistance. Let's build on the relationship between conductance and volume. We know during systole, the ventricle volume and the conductance of the blood pool decreases. During diastole, the ventricular volume and conductance of the blood pool increases. We can draw the conclusion that conductance and volume are directly proportional. Furthermore, we can conclude that conductance provides a real-time direct measure of volume change during the cardiac cycle. Now that we understand how to relate conductance to volume, let's discuss why we must consider calibrating the volume signal obtained via PV catheter. As discussed previously, the local electric field created by the distal and proximal electrodes not only captures the voltage potential of the blood, but also that in the muscle wall. We call this parallel conductance. We perform hypertonic saline calibration to determine the ejection fraction of the actual blood in the ventricle and thus determine the parallel conductance. Ideally, the catheter will capture all volume within the heart. However, due to the need for excitation electrodes and a pigtail, this is not a reality. Therefore, a cardiac output or stroke volume correction must be performed. We use Bond's equation to convert conductance to volume. The equation accounts for cardiac output or stroke volume correction factor as alpha. The parallel conductance represented by Gp is removed from the total conductance measured from the catheter in order to isolate the conductance of the ventricle blood pool. The electrode spacing is variable within catheter model. There are two approaches to volume calibration in conductant T. The first approach is a reference volume calibration. The second approach is determining the ejection fraction in the ventricle by measuring the increased conductance of a bolus of hypertonic saline. It also includes performing thermal dilution per standard protocol to normalize the volume data using a cardiac output correction factor. It's important to consider which calibration method is most suitable for your study before creating a protocol. If you're interested in relative volume changes observed during baseline and therapy treatment, you can consider performing a volume fit calibration using echo or MRI reference volumes. If your protocol requires absolute volume changes or the need for independent volumes from echo or MRI, you should consider implementing EF-Cal and SV-Cal in your study protocol. Volume calibration in conductant T is performed in the VC volume calibration window located in the top toolbar. The VC volume calibration mode enables the user to analyze and apply reference volumes, EF-Cal and SV-Cal calibrations. Prior to applying any volume calibration in conductant T, always collect and review the baseline reading to make sure end diastolic and end systolic markers are being properly traced in the pressure and volume signal. You should also remove any segmental volumes that are out of the ventricle. For data quality, ensure to collect 15 to 20 seconds of baseline data. To apply reference volume calibration, access the dataset containing the data recordings. Select the baseline reading. You can view the baseline reading by highlighting the file name and selecting Show to display the data. It's good practice to take the time to scroll through the data recording to make sure the beats are properly selected in conductant T. You can right-click on the beat number to access options to exclude, split, and merge beats. For a reference volume calibration, you will need at least 2 of the echo value entries. You can select to use end diastolic, end systolic, and ejection fraction. Reference volumes from echo or MRI can be used. However, MRI provides the highest accuracy. You should consider using MRI when available. Enter the end systolic and end diastolic echo values in the echo values window, then select Apply. Conductant T will run through the data set and perform a reference volume calibration. As discussed, for a study requiring absolute volumes, you will need to implement a hypertonic saline and thermal dilution protocol as part of the PV loop case. Both hypertonic saline and thermal dilution should be performed after PV catheter introduction and after verifying optimal catheter placement, as you would need to collect conductance signal from the PV catheter for each step. In conductant T, the EF-Cal calibration mode is used to correct the parallel conductance from hypertonic saline runs. When ready, administer 5 to 10 milliliters of 5 to 7.5% hypertonic saline bolus through the distal port of a thermal dilution catheter. Record each saline bolus in conductant T. At the end of the recording, label the file and save as a EF-Cal file type. It's recommended to hold respiration during each hypertonic saline bolus to eliminate respiration artifact in the volume signal and improve volume stability. The SV-Cal calibration mode is used to correct cardiac output collected from the PV catheter to a cardiac output determined by thermal dilution. Record 10 seconds of stable thermal dilution runs in conductant T. It's recommended to collect 3 stable runs for patients that are able to withhold breathing and 5 stable runs for patients on ventilation. At the end of the recording, label the file and save as a SV-Cal file type. In this PV loop view, we see the total volume signal and PV loop collected during a hypertonic saline bolus. During each hypertonic saline bolus recording, make sure the total volume shows an upward shift, indicating a rise in conductivity. You should also notice a rise shift of the pressure volume loops as the conductivity increases due to the hypertonic saline bolus. The pressure signal should be unaffected and should remain stable during the hypertonic saline runs. After collecting the hypertonic saline bolus runs and thermal dilution, you can perform the calibration analysis for each step by going into the VC window. The hypertonic saline files are located in the saved EF-Cal dataset. Before applying any saline bolus run, review each saline bolus recording to make sure conductant T has selected beats showing the volume rise, indicating the increase in conductance. Conductant T will automatically attempt to detect the rise in conductivity. However, it is good data quality practice to review the calibration before applying. You can right-click on a beat to add or remove from the calibration range. After you reviewed each saline bolus run, check the files you'd like to include in the EF-Cal and select Apply. Conductant T will remove the parallel conductance from the dataset. To perform a SV-Cal cardiac output by thermal dilution calibration, access the thermal dilution recordings by opening the SV-Cal files. You will also need to manually enter the cardiac output reference values collected during the case for each run in the cardiac output reference box for its respective thermal dilution recording. Before applying the cardiac output thermal dilution averages, review each thermal dilution recording to make sure beats are consistent. You can right-click on a beat to add or remove from calibration range. After reviewing each thermal dilution run, select the thermal dilution recordings to include in the calibration and select Apply. Conductant T will apply the cardiac output calibration to the data set. After conductant T has applied the volume calibration, the PV loop and the data views will convert from a red to a yellow tracing. In summary, there are 2 approaches to volume calibration in conductant T. When relative volume changes are sufficient to assess the effects of a therapy, a reference volume calibration offers a simple and straightforward solution for volume data correction. In order to obtain absolute volume readings, a parallel conductance and cardiac output correction must be performed using the EF-Cal and SV-Cal calibration. So at this point, we'll open up the Q&A. Feel free to go into the questions panel and add any questions that you'd like answered pertaining to volume calibration or the INCA system. If you'd like to reach out to us directly, you can do that at support@millar.com for any support inquiries. If you're interested in sales inquiries for the INCA system, shoot us an email at sales@millar.com. And also at the end of the webinar, there will be a survey where you can rate today's webinar and also comment if there's any future topics that you would like for us to discuss. So at this point, I'm just waiting for some questions, and I also will bring Jan into the discussion. Hi, Jan.
Hi, Noemi. I'm here.
Hi. Okay.
Hello, everybody. Good morning.
We don't seem to have any questions at this time. Do you have anything to add to the presentation, Jan?
Yeah, maybe whenever you are going to calibrate using the hypertonic saline and the stroke volume determination with Thermolution, you can better not save those data directly in SVCAL or EFCAL files, but you should better save them as just data files. And later, when you have time during the experiment, you can go back to analysis, and you can move those data files from for the stroke volume determination and for the EFCAL, the hypertonic salines, you can move them to the right boxes. Okay. Whenever you're going to do assign them directly to SVCAL files and hypertonic saline files, then the program immediately starts calculating, and that will take some time, so you cannot record quickly after that.
Okay.
Is that clear for you?
Yes. So in other words, during the case, after doing a recording, you get a pop-up window that basically allows you to title that recording, and also it will, I think I may have, it will allow you to save that recording in a specific file. So you can do that and place it in the SVCAL or the EFCAL, or just save it as a regular data file. So what you're saying is just save it as a regular data file, because the system starts automatically running that calibration in the background. So it's best just to do it post data analysis, where you can go in and actually place those data files as SVCAL or EFCAL.
Yeah, so better don't do it during the calibration episode, especially when you are at the cath lab or during surgery. Everybody has to wait then a little bit longer, so it will take more time then.
Okay, so we have some questions now, and the first one is it a must that we have to do the thermal dilution cardiac output measurement while recording live file, inject and record at the same time? Can we do them separately within minutes?
Yeah, I should do that in real time together. At the moment that you perform this Thermolution measurement, I should also record, do an acquisition of the PV loops at the same time.
Yeah. So in other words, you need the system to collect those cardiac output thermal dilution runs while the catheter is in.
Preferably. Huh?
Okay.
When you don't work in real time, it can add to less accuracy. Say, whenever you record these Thermolutions or take them already prior the insertion of the PV catheter, the baseline hemodynamics can have been changed in between.
Okay. We have two other questions related. How to use saline with the 4-fringe catheter?
Similar as to 7-fringe catheter. You inject the saline in a Swan-Ganz catheter. You inject it in the pulmonary artery when you have the catheter in the left ventricle. And when you have the catheter in the right ventricle, you inject in the central venous compartment. You don't inject the saline in the lumen of the PV catheter. You inject it in a separate line.
Okay. That seems to be all the questions we have for today. I'll allow a few more seconds to see if anyone else decides to ask a question. Yeah, so it seems like my platform's not updating the questions. Okay, Jan, I think that's all the questions we had today. Actually, here we go. We got two more. There seems to be a little delay on my questions panel. Okay, is it necessary to calibrate to estimate ejection fraction?
Depends. Depends on the study. Whenever you go to intervention studies, they are going to measure pressure volume loops during a mitral clip positioning. It is not that important to have a very precise ejection fraction. You can better import the MRI data or the echo data. And at the same time, in that case, with mitral clipping, you need forward cardiac output, and then you still have to put a Swan-Ganz catheter in to get the best results. Whenever you really need accurate independent volume measurements, you can best go for the hypertonic saline combined with thermolution.
Okay. Another question that we have, we see a difference between the two methods of calibration. Any comments?
There can be differences. The accuracy of volume determination by echo is very low. For a left ventricle, it is plus or minus 30%, so it can vary a lot. The MRI accuracy for left ventricle volume is much better, and it is plus or minus 15 up to 20% accuracy. The combination, the independent combination by using hypertonic saline and thermolution, you can reach even better values with an accuracy of about plus or minus 15%. So in all cases, the accuracy of volume determination in general is quite inaccurate. And that's already for the left ventricle. For the right ventricle, it is worse. Right ventricular estimations of right ventricular volume by echo maybe are in the region of plus or minus 50% of the real thing. With MRI, it can be better. And with the conductance technique with hypertonic saline and stroke volume, you can still be in the reach of about 15% accuracy.
Okay. We have another question. When we do multiple SV cal, what is the criteria to decide which ones to include, which ones not to include? The same question for the EF cal.
Yeah, better show now the EF cal
sure.
Slide, and I can better explain.
Okay.
Here in the volume calibration box left under, you see the data of demo 04 and demo 005, saline 1 and 2. Then you see a number EF cal, that is the parallel conductance measured as estimated by the hypertonic saline. Then you see a small box with EF and a small box with R. And in both boxes you see 0.99 in all boxes. And that's the correlation coefficients of the method. And that should be near 1. Now, this is a kind of ideal measurement done, but sometimes you will have lower correlations, but then you should go for the best correlation factors. And they are represented by the box EF and the box R. For stroke volume, it is similar. Here we have, in all cases, about the same resolutions, but it can vary. In normal cases, you can have a marked variation between the resolution measurements. You should take care that the recordings simultaneously with the conductance catheter are of a length of at least 15 up to 20 seconds. And then you need to include all of these values of resolution. And resolution can vary quite a lot, especially when the patients are on ventilation, and you can have a very natural change in venous return, which will affect the resolution determination of one example. And that's why you need, especially in patients on ventilation support, you need at least to go for 5 resolution measurements. When you can stop the ventilation, then you can best determine during a ventilator stop. Then you only need about 3 runs for the resolution. But don't go ever under 4, except then whenever you have a ventilator stop. And with spontaneous breathing, it can be that the patient is very dyspneic, and then you have also huge variations in venous return. So take care, and then even breath hold maneuvers can give a false bad effect on venous return, and the patient can easily go into a kind of Valsalva maneuver and decrease in cardiac output or venous return same moment. This kind of information is all from publications already from the 90s, from the last century. But whenever you want to know, we can give you the references.
Okay. And it seems like that's all the questions that we have today on. Thank you everyone for joining. Again, there's going to be a survey at the end of the webinar. Please feel free to add your comments, to rate this webinar. Thank you all for joining and have a nice day.
Okay, have a nice day.